My name is Tia Mefford, and I am currently enrolled in the ACMP program at UAH. Today I'm going to be completing a comprehensive diabetic foot exam. I've already obtained consent from my patient to perform the examination and to record it. My patient is a 27-year-old male with no prior history of diabetes. However, both his grandfather and his father were diagnosed with type 2 diabetes. He stated to me that he is on his feet approximately 60 hours a week, owning a lawn care company, so if he was diabetic, this would be an important examination for him to complete. To begin with, I'm going to look at the musculoskeletal structure of the foot. I'm going to be looking for any calluses or cracks or signs of previous ulcers in his foot and skin. I don't see any cracks or flaking skin around on his foot. And I don't see any signs of any previous ulcers, but I do see signs of callousing here and here, also here and here. I don't see any bunions or hammer toes or any digital deformities. Noting the calluses is really important if the patient's diabetic, as it can often be a precursor to an infection and ulceration. It can often lead to a blister that may have an ulcer underneath. While I'm continuing to look at the structure of his foot, I'm going to look for any digital deformities, including plantar flex metatarsals. He has a flat surface here, which is important. If he had plantar flex metatarsals, one would be down more than the other, leading to increased pressure in that site and an increased risk for an ulcer. But he doesn't have that problem, but that's something you want to look for. Also, you want to look for Charcot's deformity. Charcot's deformity is when you lose the structural integrity of the arch and the foot kind of folds down into like a rocker bottom. It can obviously lead to increased ulcerations to that area and infections. The problem is it happens slowly over time, and often patients with diabetic neuropathy don't feel it. So that's something that you want to monitor for them. And I don't see any signs of Charcot's deformity. He has a good strong arch. While I'm doing that, I'm going to check. While I'm looking at his arch, I'm going to be pushing back on his feet. This is going to check for equine's deformity. He does not have equines. What that is his foot goes back farther than 90 degrees, which is what we want. If it wasn't able to, that means that he would have a tight heel cord and that he has a increased chance of putting more pressure on this plantar part of his foot and increased risk to develop an ulceration there. But he is negative for that, and he's good there. While I'm holding his foot, I'm going to note the bottom of his feet, the plantar temperature of it. You want them to be the same. His are the same. Both have same temperature. If one is warmer than the other, that can be a sign of infection. Also, you want to ask your patients to note the temperatures of the bottom of their foot, because when one is warmer than the other, it's been shown that if they decrease the activity with that foot until the temperature equalizes, it decreases their risk for loss of limb, especially in high-risk patients. That even though it takes several days, it does make a difference as far as decreasing the risk of infection and limb loss in high-risk patients. But he has a good temperature on both sides. I'm also going to look at his skin. I'm going to look for signs of flakiness, maceration, wetness, a rash, a tinea pedis, which is also known as athlete's foot. You want to look between the toes, look and see if he has cracks or ulcerations there. If he did have tinea pedis, we would prescribe a topical antifungal. But his are good. While you're there, you want to look at his toenails. You want to look for signs of thickening, which can be a sign of a fungal infection, or ingrown toenails with redness or warmth to the site. He does not have either one of those, but that's an increased risk for infection for someone who is diabetic. Now we're going to look at the circulation. We're going to palpate his dorsalis pedis and his posterior tibia of both feet. Very good, strong pulses. If they were weak, it would be a sign of poor circulation, decreased circulation. Also, you want to check capillary refill. This is less than 2 seconds. It's really good. If they had decreased circulation, that'd be at an increased risk for ulcers and sores and infection to develop also. You want to note and see if he has any swelling in his ankles or feet. He does not. And we're good there. Next, we are going to check his sensation using a monofilament. I'm going to have you close your eyes, and I want you to tell me if you can feel this, or just say yes when you do feel me touching your foot.
Yes. 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 Yes.
It's 5 out of 5 on his right.
Yes. 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 Yes.
And he's also 5 out of 5 on his left. His sensation is good and intact. Abnormalities would be if he didn't feel it in one or two areas. You always want to make sure you check the same areas when reevaluating. If he didn't feel it in one or two areas, that would be a decrease. That'd be a sign that he has a decrease in his protective sensation, which is what the pressure you feel like when you were to step on something. You can also help patients reassess that and check their feet, especially if they have a decrease in one or two areas that they didn't feel. Is you can give them a monofilament to take home. You want them to notify the provider when they can feel the sensation again. We know that they aren't going to feel the sensation again, but it's a way to have patients who especially have decreased sensation at their foot to look at their feet often and notice if they have any blisters or infection, and more likely to have an early intervention and get in touch with their provider. Next, we're going to check the vibratory sensation of the foot. I want you to tell me when you can no longer feel this.
Now.
Okay. And this one.
Now.
Okay. He had a normal response, which means that when he said he no longer felt the vibration in his foot, I also no longer felt it in my hand. An abnormal response would be if he no longer felt the vibration in his foot, but I felt it in my hand, and that's an indication of the very beginnings of diabetic neuropathy and would need to be followed closely. Next, we're going to check his sharp and his light and sharp sensation. I want you to tell me if this is light or sharp.
Light. Light. Sharp. 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 Light. Light. Sharp.
And his light and sharp are intact. I'm going to check his reflexes. I want you to just kind of relax your foot here. Okay. He's got good response in his reflexes. If he had absent or decreased response, it would be a sign of advanced diabetic neuropathy, but his were strong and intact. Next, we're going to talk about he had a normal foot examination. If he was diabetic with this normal foot examination, we wanted to see him annually, at least once a year. If he had neuropathy, but no signs of issues currently other than neuropathy, we want to see him at least every 6 months. If he showed signs of neuropathy along with poor circulation, we would want to see him at least quarterly or like every 3 months. And then if he had previous ulcers or signs of possible ulceration developing, we would want to see him a minimum of every 2 months. Additionally, we want to talk to him about his shoes. I'd want to see how his shoes fit on his foot, make sure that they weren't too tight or too loose, any additional areas of rubbing on the foot that can cause problems, and always remind them to put their hands in the side of their shoe first, especially if they had decreased sensation, to make sure that they're not rubbing their foot over something. Also, we want to talk to them about the importance of glucose control, checking their glucose at home, and the complications that can develop of neuropathy. And this was our diabetic foot exam.